All right, good morning. It's our privilege to open session number 1. And how perfect is it that Dr. David Adams is going to give the state-of-the-art lecture on analysis to reconstruction. Dr. Adams.
Well, we're just going to continue the discussion that Tirone started, and that is around anatomy and understanding anatomy, which is going to drive your reconstructive strategy. These are my disclosures. And so I'll take you back and remind you, in the French correction, this is the figure that everybody remembered. And by the way, this was the operation that was done in most centers for mitral valve repair. Tirone mentioned this is how he started. Everyone started this way: quadrangular resection of the prolapsing segment, annular compression, and then a rigid ring. So this was the foundation of mitral valve repair that Carpentier first established and applied, and was the main description in the French correction. There are many more things in the French correction, but this was a hallmark of valve repair. And many, many years later, I had the privilege of helping him put this book together where things really did evolve. And you can see the title, From Valve Analysis to Valve Reconstruction, which is something he felt very strongly about and is really the topic of this discussion this morning. If you look at where we went then, this was 2004 to 2010 versus where we were in the 70s and 80s, you can see how his philosophy sort of how to deal with prolapse had evolved from simply resection and compression to thinking about different shape incisions and thinking about whether to attach leaflets or not, depending on the amount of leaflet tissue. And I think that really showed like how the reconstructive field was starting to mature. And Tirone already showed you this figure, and I drew that figure on the back of a napkin literally one day. We were doing a live course, and we were thinking about ways to tell surgeons about how to select your club, what you're going to shoot. It wasn't really about trying to do anything else other than to think about small tissue or big tissue or excess volume or very minimal tissue. And it was funny when Tirone said that the younger people go to the Form-Bruce and the Barlow side, and they're the more complex. Actually, the more you do this stuff, the one that you worry more about are the ones that have really minimal tissue, a little bit of calcium at the base, very unforgiving. The big Barlow, you got lots of shots to try and sort out. But at any rate, it was really foundational for me in terms of thinking about, in my own journey, how to sort of think about resection techniques. And we continue to evolve that. And this was something we put together a few years ago for another course that was just showing all of our thought processes now about volume, height, adjacent segments, clefts, and indentations. So there are lots of things actually to think about, and what that slide shows and what Tirone said, and I'll confirm, it is a really broad spectrum of anatomy and lesions, which is why it's really a fun field, because every single patient brings different things to the table. The other thing I'll challenge everybody about is, it doesn't matter to me what annuloplasty ring you use. Sometimes when I say that when you're in a pickle, you can just take out a piece of pericardium and almost repair anything. So having said that, I do think that, you saw Tirone's video as well, and you almost implanted it the same way as that last ring. Going a little bit past the posterior commissure, I noticed. We'll talk about that later maybe in the discussion, but I do think we have moved almost exclusively to open products, and we have been doing that for many, many years, starting with flexible bands and now with this sort of a ring that has differential flexibility and shape, but leaving the anterior curtain untouched. The other point I'll make, particularly to people that are in less experience with mitral valve disease, is you have to understand echocardiography, and these are the 3 views you have to know. For the anesthesiologists always want to show you the 3D. That's for fun. The only reason 3D helps you is when you have a residual leak. It can really help you locate it. But at the beginning, you've just got to know the 4-chamber commissural view and long axis. You can learn everything about every valve you're about to repair with that. There are no surprises in the operating room. I never understand that it's a 90% repair rate. modern echocardiography with good knowledge, you can almost invariably predict what you'll find in the OR. There are some subtleties and nuances, but it should either be, I'm not sure till I get to the operating room where I look at the echo and I know exactly what I'm going to do. And that's really the point here. Valve analysis, which starts with echocardiography and then is confirmed in the operating room, really is to identify dysfunction in lesions. You need to address all the lesions. It's not just prolapse. Our eyes are drawn to chordal rupture, but what we really want to think about is height and volume of leaflets and chordal support. We've got to have a good surface of coaptation. If one thing that's changed from the resect and respect discussion over the last decade is we want deeper closure lines. We want more of the leaflet. We want more praying hands below the annulus. And again, remodeling the annulus is really important, and it's something that I don't think is just picking a ring and throwing it on there. There are lots of nuances to that based on the lesions, and the best way, I think, to have this discussion is to show you 6 edited videos that will sort of walk us through some of the pathology and some of the decision-making. This is the first patient. You can see it's a simple prolapse, single chordal rupture, posterior leaflets, has a flail segment. It's not a very big valve, very straightforward. And again, there are no secrets in the operating room. Here's the chordal rupture, adequate tissue, not a particularly large valve. And so you put your annuloplasty sutures in and you look, and we use ink all the time. We really do use that a lot to sort of give us reference points and think about things. But this valve could be repaired multiple ways. But in this case, I think that the simple thing is a resection. And we always look at these adjacent segments because sometimes we can use an adjacent segment as part of a triangle or a quadrangle. But in this case, we'll do a simple resection, and you can see we don't need to go to the annulus. We're not trying to control volume here. We're simply trying to control the margin width and then the re-support. And so that's why we took our time to look at those chords. And if you remember with the hook, I showed you a thin chord. And so that's also important because sometimes when you'll do this, you'll just do resection. Sometimes you'll want to add Gore-Tex as well. There's no reason not to blend approaches. Here, that Gore-Tex is not to correct prolapse. It's for durability. And so we blended an approach. I told you it wasn't a very big valve, size 32. And extremely straightforward and very straightforward in the echocardiogram. And again, many ways to repair it. That's the way we typically do if we see thin chords and single segment prolapse without excess volume. So here's the second case. This patient's 38, and you can see this one's got a little bit more volume, still a sort of central jet, and then this posteriorly directed jet. It's a little bit more interesting, but same principles apply. Larger prolapse now, very different. They're both P2 prolapse. Now you have one that has smaller adjacent segment, larger prolapse of the P2 segment with extra width. And so here's a patient where we're going to do something different. We're going to elevate P1. You can see we're going to detach it for a fingernail length from the annulus. And then we're going to rotate the body of P2. We're not going to cut P2 out. The old days we just do quadrangular section plication, P1, P3. But we want to create deeper surfaces of coaptation, so we take advantage of the extra leaflet tissue. So you can see we're going to cut both primary and secondary cords there, release the leaflet, and do a simple transfer toward the elevated P1. And so just like Tirone said, we're going to resew it into the atrioventricular junction. And now you can see we're going to have about a centimeter tall, 1.5 centimeters tall posterior leaflet. First step is not to worry about chordal support. It's about height and volume of the leaflet. So now we've done that. Now we have our height right. And now we can talk about support, whether we need to do anything else or not. Next step is to obviously reconstruct the leaflet. Coaptation looks good. Assess the chordal support. Make sure we're happy with the native chords. We do interrupted sutures at the margin so we can take it in or take it out. You can create restriction too if you're not careful. Again, our instincts, if we're not 100% happy with cords, is to add a Gore-Tex cord just for security. Sometimes you can also use that to displace it a little bit in terms of optimization of a closure line. And that's what we're doing here. Like 2 simple knots so we can move it up and down. Important because it's the same size ring, more volume, more leaflet tissue, so you want to make room for the anterior leaflet to excurd. So that's, again, simple prolapse, 2 cases of posterior leaflet prolapse that are both straightforward. They're all straightforward once you get in the habit of using the lesions to guide the resection strategies and not get caught up in one or the other. Here's a 57-year-old patient, more tissue, more volume. A surprise we couldn't see on the echocardiogram in the views, at least that I'm showing you, which is this calcified fibrotic papillary muscle and chordal apparatus there. Much more volume now, and now the leaflets are rolling on each other. And so this patient obviously needs a resection, and the question is going to be where we're going to do the resection. And again, we'll let the anatomy do that. We'll fill the ventricle with saline, visualize it, oftentimes mark it, pick an indentation or cleft that we're happy to. Usually it's the tallest segment. You don't have to take everything all out at once. You can tailor that as you go, but we want access to the subvalvular apparatus so we can take out whatever else is there. If it's fibrotic cords, they're restricted, we'll cut them. Here you can see this sort of calcification down here we're going to take out. These are not en-bloc resections of annular calcification. These are really ossified papillary muscles and chordal apparatus. I think it's part of the arrhythmic prolapse syndrome that we'll talk about later, but you can see how, and I don't know why it's always almost invariably involves the anterior commissural area, but it does. But now we're just sort of releasing P1 and taking out this fibrosis and calcification to be able to put the leaflet back together again. And again, we don't need to worry about how much height there is. We can tailor that, just like when you're closing an aorta, doing an aortoplasty, we can tailor the height of the leaflet with where we move our needles in terms of on the height of the posterior leaflet or anterior leaf or the posterior leaflet. Resection, Gore-Tex common because we don't care about where the cords are. We don't do resections based on cords. We do the resections based on volume. And there again, looked more complicated. It was almost an identical operation, the 2 simpler ones that I showed you. But it was just about picking the reference point and how to start. So now we move on to the bigger valve. You can see that in the commissural view, the more cauliflower valve. And this is fun too. Now you just have a bigger valve. You can see it's a much bigger amount of tissue, more circular valve, more like that figure shows, the circle at the end of it. The leaflets are just rolling on themselves. You can make 3 mitral valves out of this amount of leaflet tissue. And so here's someone, again, we like resection, so we'll use our hooks, pick our reference point we want to keep. We never look at P1 and measure with hooks against everything else. We try and just pick a reference point. In this point, it really was on the other side that we were looking at. And now we can make a more generous quadrangular resection. You notice each resection is basically tailored to the anatomy in front of us. The valve decides what we're going to do. We don't go in there with any predisposition of what shape resection or whether we're going to resect for that matter. But here you can see a little bit different opportunity because we need to get these leaflets to the same height posteriorly, which means we need to do a more advanced resection and then reinsert the valve at the correct annular level. And again, trying to get this down to about 1 centimeter. And you can just travel along the leaflet and do that invariably. And you're creating tension on the residual cords, which helps you with residual prolapse. But there's a more extensive sliding plasty because that technique really helps you if you have this infolding of leaflets. Same standard leaflet reconstruction, assess the marginal cords, and true size the annuloplasty. So more straightforward, you can see just more tissue, same technique, same philosophy, cut a secondary cord, add a Gore-Tex, pay attention to the free margin, do some saline testing. 5 minutes with a hook, you can really perfect these things. And now you can see it's a much larger valve, a 38 now. But almost every echo, and I always say that, almost every echo looks the same, doesn't it? Same height of posterior leaflet, same closure line, same displacement, and that's what you want. That's what real valve analysis will let you do. Then the last two cases involve the anterior leaflet as well, at least this one doesn't. You can see the simple anterior leaflet prolapse. And anterior leaflet prolapse, no resections unless you've got very special circumstances, which is not the topic of this talk, but here's a case where you've got a simple prolapse of the anterior leaflet, and the key with the anterior leaflet prolapse is very different than posterior leaflet prolapse. Almost all these operations should be very fast because they're going to involve minimal resections in most circumstances, and you can see the prolapse here of A3. Height of the posterior leaflet looks pretty good. Always look at the posterior leaflet. Sometimes you still will find a defect there that you may want to treat in terms of long-term durability. Back to Tyrone's paper, we got to really work hard to get these anterior leaflets to stay durable. But here we'll mark chords that are good. So we've identified chords that can support this leaflet, because that will help us in case we decide to do that. It also helps us where we're going to place chordal transfer, which is what we're doing here. That's a secondary chord we're releasing. We'll use 5-O-proline to put it back into the margin. I like that when we can see them. We never would rely on that complete as the only repair strategy anymore, although that was Carpenter's main strategy. In one of our first series of valve reconstruction, we only used Gore-Tex in 4 patients, back to Pat's contribution, which is, you can really do a lot with native tissue if you understand how to do that. But I love that because it sets the reference point. Carpenter would put a ring in right now, I can promise you. So just one simple chordal transfer took care of it. This is because of Tyrone's paper. That's what I always say. I have said it for years. That's why we do that. That's why I stopped doing just chordal transfer that Carpenter taught me and started adding Gore-Tex, because of the long term. I learned that from Jabreen. First 2 knots at the annular hinge of the anterior leaflet. And now you can see we've got this sort of belts and suspenders approach, true size of the ring. Couldn't be a more simple repair if you just have a couple of basic foundational concepts that you're going to attack these valves with. They should all be repaired. These are very fast cases, and I promise you these are repairable by everybody in this room if you do those 2 things. And then to finish, the last case really sort of, I think I might have hit that button too soon. The last case really summarizes everything, and that is the where you've got everything going on. Let's see if we can get the last case to come up back there, guys. I'm not sure what happened. Any ideas? Gentlemen, the last slide just went off. Let's see if we can find case 6 real quick, because it's kind of important. Just move forward slowly. I know it's a big file. Don't go too fast now. Hit the button one more time. I don't think so. Let's go to the video, see if we can see the video. Oh dear. We did look at that back there. Let's just give it 1 minute and see if they can figure it out. I think you've got the hang of it. I wanted to show you this because this really takes you through the rest of it, which is bileaflet prolapse and how to really do this.
Can I ask a technical question while
Sure.
we're waiting? Okay, so on case 2, where you elevated P1 and then slid P2 underneath. So that takes a little bit of vision to be able to see when you first get in there that that's the ultimate relationship you're going to establish. Do you have any hints or analysis clues on how to look for whether that's the right setup?
Yeah, I think if you remember, Joe, that P2 was very tall. Mm-hmm. P1 was tall enough. The other option there was to divide P2 and take out a triangle at the base of it and accept the P1 height. But there, in those circumstances today, we try and take advantage of the extra tissue and make it taller, and then know we can use Gore-Tex to drop it deeper in the ventricle if we want to. They both would work.
So are you trying to generate uniform posterior height across P1 all the way across P2 and into P3 nowadays?
That's our goal, is trying to do that. And invariably, and that's something Tirone always comes to my live courses, and he moderates, and then he always tells me in front of all the surgeons, Dave, I don't like what you're doing. And he never does. I'm trying to do one operation with him that he likes everything I did. Because I do like doing these remodeling, these little indentations to create support. You've done it. Now watch. Okay, there you can see the pathology, and I hope you guys can appreciate the dueling jets here. So now you know, there's no surprise here. You know you've got bileaflet involvement. Look at the commissural view. Look at the cauliflowering of the leaflet, the real floppy valve paper that Tirone showed. Okay, hit the button one more time. We'll hope for the best. You did it. Now look at this valve. Only focus on the posterior leaflet first. Don't worry about the anterior leaflet. I only pull it out for you. I usually just leave it in the ventricle. I don't care what's going on with the anterior leaflet until we get the posterior leaflet correct. So we've got excess tissue, a ruptured freestanding segment in the posterior leaflet, this abnormal indentation, lots of tissue everywhere, bileaflet sort of tendency to prolapse. The way you attack this is the posterior leaflet. The anterior leaflet, don't think about it. Get yourself a good coaptation zone in the posterior leaflet. Again, many resection techniques, many ways you could do that, but we will tend to cut out in a circumstance like this. Our eyes are drawn to where the leaflet's prolapse, so unless there's a reason not to, we will. Here's some annular calcification at the base of the valve. I don't know whether I'd call it annulus or just the attachment, the base function is calcified. Always good to take that out. That's where sliding plasty helps you cover that. So we don't want to leave that exposed. So we cut secondary cords to move that over, very short transfer of tissue. But again, can't address the anterior leaflet till you've addressed the posterior leaflet. Now your eye already tells you that the A3 side is prolapsing. Here's this little chordal rupture, Gore-Tex cord, just like we talked about. 2 knots at the tip, adjust it with saline. You have the annuloplasty effect with the ring sutures. You're going to true size the valve. Valves in, now we have perfect coaptation. Now we can appreciate we still have work to do on the P1 side. We're going to remodel P1 a little bit. We're going to add a Gore-Tex cord, and now we're going to have symmetry. So sometimes the final tailored happens when the ring's in place. That's when you can really see it. And then that's the final summary. Echo helps you find the lesions, look at the dueling jets. Your surgical analysis is confirmatory. It also takes some time. Don't be in a rush to get the scissors. Really think for 2 minutes. Fill the ventricle with saline after you put your annuloplasty sutures in. Once you've confirmed the lesion, that's when you develop your strategy and attack. And I think if you follow that, I think you'll find valve analysis really is the most important word. Thank you very much.